Any other apologies? No?
We've not received any other apologies.
Okay, thanks, Firoza. I think I was talking about the minute of 9th of June, 11th of March, but unfortunately, if we are not correct, we cannot approve those minutes. Declaration of interest. There is no public questions. Item 3 is Better Care Funds, Q4 2019-2020 update. Said Sub.
Yes, Chair. So the Better Care Fund, if Wendy, if you want to present the report, and I'll scroll through it. So this is a regular report, Chair. This is the a report which needs to go in terms of Court 2. As far as progress is concerned, the Better Care is a very important aspect of how we work integrated with our CCG partners and in terms of commissioning with the third sector as well. In terms of background, you know the background, we regularly go through that, so I'm going to skip down to the bottom of page 2. So as far as key issues are concerned, from a point of view of looking at the overall funding, it's still a significant amount of funding, so it's nearly £14 million. That funds in the main a number of different schemes, and of those schemes we're tracked on 4 of those. So if you want to scroll down again, so take you to bottom of page 3, which is 5.1b. And essentially, you're looking at a breakdown of funding there, but then you're looking at the allocations which make that up, and it shows you the pooled amount of the budget amounting to £23 million. Going down to the performance update, which is at the top of the next page, and this is predominantly the most important aspect of what we're measured on. We're on track on 2, and we're not achieving on 2. So if you remember last time round, Chair, we'd moved from a position of achieving on 3 out of the 4, and previous to that, we were struggling to achieve on anything other than 1 out of the 4. So the one we've shifted on, which we shouldn't have shifted on, is the reablement one, which has been the one that we've consistently achieved on. But I'll give you some background to what's going on there. So at the moment, we're on track on reduction in non-elective admissions, which is good. We've done a lot of work with the system in making sure that the non-elective admissions are used in the correct way. In some respects, if we're not achieving on this, that does mean we are providing better care, because what it means is that if somebody turns up and they've got a condition or something that needs treating, then we're admitting those people. And previously, you'll recall, we did a more detailed update on why non-elective admissions were going up and what the underlying issues were. So in some ways, good performance means that you're on track and you're doing more things through an elective process, which means it's more managed care. But that said, if you're also in a position where you're having to admit people because they've got urgent conditions, then that in itself isn't bad performance. One of the things I'd like the committee to perhaps reflect on is that as we go forward, we may have a backlog of comorbidities and other issues that have not been treated as a result of COVID. And they may be with very vulnerable people. So I would fully expect that non-elective admissions go up in the future. And that would be because we're now moving into what the NHS is classing as phase 3, which is to move towards restoration. And the government, through the Department of Health and Social Care, has gone on record to say restoration in phase 3 needs to be bigger and better. So what they're expecting us to do is to recover some of the backlog from people who've not been able to receive the treatments that they would have ordinarily have received had we not had COVID. The second tracker on there is permanent admissions to residential care. So we're continuing to make good progress against this. And if you recall, Chair, this was a very stubborn measure which we had a strategy for, and I always sort of said that it would be a matter of time before we start achieving that. So we're now in that space where through various schemes, extra care schemes and other things like that, we have started to reduce and have sustained reductions in admissions to residential care. So I think this is a real positive one for us. I think Albion Mill completing in the autumn will further add to that. Starting to deliver intermediate care as a system will also add to that. So I'm confident that this measure will continue. We're fully expecting that the regulated care sector will be under significant pressure during the winter months as we see a winter surge. The third one is the reablement target, which, as you know, we have generally performed really, really well. The problem with the reablement target at this moment in time is because the government has asked us to support discharges and to ensure that we are taking more people out of the hospital setting to reduce the risk to them and their vulnerability to COVID. We have seen a significant increase in complexity in reablement, and we're actually seeing a lot more people who need more support. So that's the only reason why we're not achieving that target. It's the volume and complexity of people that we're treating is the main issue. On the delays of transfer of care, that is still a challenging target for us. It's what the government has stipulated we must be closer to achieving. And with that, the challenge again has been the demand on social care has been greater than what we've been able to meet, and that will continue to be the picture for the foreseeable future. We don't see a change in that. Phase 3 of recovery for hospital will further put pressure on social care system, and winter will also put significant pressure on our system as well. So if you want to scroll down, we do have at the end of this presentation or this report a case study which I'll take you through very quickly, and then I'll open up to questions. So the case study at the end of the main report after page 8 is about a person called Martin, and this is a fictitious name, and basically what this case study does, it highlights the complexity of the sort of issues we're now having to deal with. So this was a person who was receiving pulmonary rehab by the pulmonary team, and in terms of his medical condition, there were a number of different complexities. And what this case study basically is highlighting is the way in which we are working together with the voluntary community sector, with the partner agencies, in this case fire and rescue team, who have gone out and done an assessment, a home safety check on the premises, and then how we're joining things up in terms of having a complex case manager, working with our partners HUK, working with East Lancs Hospice, and what we've been trying to do in terms of trying to improve the care for individuals. So the outcome in this instance was the support this person received because they were on an end-of-life pathway, and the way in which we've been able to alleviate the challenges that this person was facing, and how we were able to improve the last 1,000 days or the end of life in the best way possible, with the dignity of making sure the family were made aware of his situation and were present at the time of death as well. So not a case study which has got an ending which is about somebody being rehabilitated through therapy and regaining independence, but equally a very important part of our system now, where end of life, I think we've talked about the last 1,000 days, is part of our age well strategy as well. It's critically important that people get the best quality of care and the quality of care that they want rather than what's available to them. And this is an example of how, through a multi-agency setting, we've been able to achieve that. So, Chair, I've not gone into great detail on the report itself. As you know, the report has many facets to it. I think the indicators are a key part of this board's responsibility, as is the challenge on them. But it's also important to recognise that we're working close in partnership with the different agencies that we commission through the Better Care Fund to ensure that we're getting the best outcomes for people. So I'll leave it there, Chair. If there's any questions, I'm happy to take questions.
Thank you very much, Aisa. Any question, comment on this report?
Chair, can I
Yes,
just ask a question? Thanks, Chair. Thanks, Syed, for that report. Just a quick question really on Albion Mill. I think that's going to make a huge difference when that's fully up and running, but it was just to ask, what are the number of bed spaces and are they fully on track now? Do you have a confident kind of date as to when that's going to sort of come on stream? Thanks.
Yeah, it's a really important question, Damien. So a couple of things first and foremost. Albion Mill will be the largest single site extra care scheme and intermediate care facility in the borough. We will have 35 intermediate care places, self-contained units, and we'll have another 75 extra care beds. Now, of those extra care beds, they're essentially 2-bedroom self-contained apartments, and of those 50 will be dedicated to older people, but we've chosen to align 25 to special needs. And the reason for that is we're increasingly seeing a need for specialist single floor accommodation that can take, let's say, people with heart conditions or other things. So we're looking at a slightly different approach to Albion Mill than we've done with Riverside Heights, which was the latest. In terms of progress, it's had a few setbacks. We've been honest about that. I think all of them have been outside of our control. So the first one was the developer finding that the constructor, Bardsley, went into liquidation just before Christmas. They did an amazing job to get new constructors on board and retain most of the subcontractors around the quality of work, went through a liquidation process and reappointed new contractors just as we were going into COVID lockdown. So we ended up with a unfortunate further delay as a result of restrictions on construction industry. But since the construction industry has been able to start work again, what we've been able to do is accelerate the program. We're currently looking at the scheme being completed in early November. They're optimistic to try and make that earlier than that, but what we're not doing is speculating now on that date, because one of the things we do have to do is we've got to start to plan care packages. We've got to start to identify people who can go into the scheme. We've got to start to align the work we're doing with the hospital and with the primary care neighbourhoods in terms of step up as well. And therefore what we're gearing up for now is a handover in November and then commissioning within the next sort of 6 weeks of that. We've got a panel that meets at this moment in time that has been identifying people that we could offer the accommodation to. We've got for the extra care a policy, which means that you've got a third who would be high demand, a third that would be medium demand, and a third that would be low demand. And that is primarily about the scheme mix and making sure that the scheme is not overly dependent and there are some independent people in there that can create a decent community as well. One of the special factors of Albion Mill, which I will look forward to inviting colleagues to view at the right time, is the community hub, which is quite a significant space that we've designed between the extra care and the intermediate care block, which would serve as a facility where we can do targeted work through our voluntary sector partners to look at further opportunities, not just for the scheme, but for older people in the area and other people with different needs coming in and using that facility as an asset going forward. Thank you.
Thanks, Syed. Yeah, I mean, yeah, it's in a good location, obviously, and there's a lot of older people in the area on both the Ewood and the Mill Hill side, and you've got Brackendale Shelter Scheme just up the street. So, yeah, thanks very much.
Anybody else? Any question, comment on this report?
Yeah, Chair, can I ask a question?
Yes, yes.
Saeed, I'm just wondering whether you think there's any correlation between the indicators. So success at keeping people out of residential care creates a risk in terms of the reablement target, because as you've said, you've got more complex people at home, and whether we just need to be mindful that there might be a knock-on effect in that respect.
I think you're right, Vicky. It's a very difficult balance, you know, and part of what we're trying to do with the acute trust is to say that we want a pathway which is about keeping people out of hospital, and that's one of the reasons why we're trying to get the GP federations to work closer with us, because we need primary care to fund and understand that there is better outcomes if you can keep people out of hospital in the first place. It does mean you're getting more complexity in people's homes. It does increase the risk, but what we find, and you know better than most, is when people go into hospital and they spend time in hospital, they very quickly start to lose their independence, and it takes a lot longer then to rehabilitate these people. Where we're seeing the pressure for reablement is the discharge pathways have been maxed out during the COVID period. So we've had more people leaving hospital perhaps slightly earlier than they would have done. And what that means is that they need more care and therapy at home because of their complexity. But it's an area of the system that I think jointly as a health and wellbeing board and as a partnership, we need to get right. And therefore, I think for us, the future should be more about step up into intermediate and then step back down into where people live, rather than having people going to hospital, because I think hospital is absolutely the wrong place for anybody unless they absolutely need to be in hospital.
Yeah, we could do with some national policy supporting that, couldn't we? Because I was in a discussion yesterday about winter planning for hospital discharge and asked that question, and the national guidance is about discharge, isn't it, rather than admission avoidance. So yeah, I guess it's all part of that same picture. Thank you. Yeah,
you're welcome, Chair. I think on that last point, the government is void of any real drive behind social care. So the Department of Health and Social Care does feel like it's the Department of Health, because it focuses on the outcomes for hospital. And I think we all are very much about an integrated partnership and a whole system, and we need to get the right influence to get our voice heard. So this Health and Wellbeing Board and the executive members on this group are a vehicle, I think, for getting that message out to the right people in government, to make them aware of our concerns. And if we could do it collectively with other local authorities, even better.
Thank you, Saeed Saab. I don't see any other hands up. Saeed Saab, on the DFG, it's almost 1.9 million pound there.
Yeah.
Due to the COVID-19, and our building department don't want to enter other people's home, etc., etc. So how is it impacting your side and children's side on the waiting list?
I think we've done several things to improve the throughput of the actual OT's recommendations and those sort of things. The big challenge we've still got is building capacity. So when people are going into people's homes, they're vulnerable. The work is being done. But when people are going into people's homes, they're having to be more careful. They're having to take extra precautions, because essentially the fact that you're delivering disabled facilities means the person in the home is likely to be vulnerable. And I think those precautions at this time are the right thing. What we don't want, though, is additional delay. So one of the things that we have been looking at is whether or not the buildings division in the council can actually consider subletting contracts to other contractors and expanding the workforce that we've got to be able to do more disabled adaptations in a more timely manner. And it's back to the discussion we've just had with Vicky about more complexity does mean that more people will need their homes adapted to keep them independent for longer. I think Chair, it's probably worthy of us maybe having a more detailed item at a future Health and Wellbeing Board just on what DFGs we've been delivering, the length of time it's taking, some of the indicators, but also some of the improvements we have made to mitigate some of the risks that you highlight. Because I think a lot of people rely on these types of improvements, but there's also some cases that we're coming across where their conditions are not capable of taking an adaptation, in which case the other problem we've got is we're not building enough new houses either, and we haven't got the quality of housing available for those people. We've got one particular case at this moment in time where a poor lady's needing to have adaptation to a home. The house is not capable of taking that adaptation. The only other option for it is to move into a housing association property, and we're having to constantly now wait for stock because there's no turnover, because there's no new supply coming in, and private renting doesn't do it. So we've got some real complex issues emerging as a result of COVID and the construction industry that are impacting on health and well-being.
Yeah, I think this issue is very important for a number of years for me, because I don't want the people who need adaptation, they will be waiting for 6 months or 8 months, 1 year.
Absolutely.
That is their quality of life, and that could impact those people that end up in hospital, fall and other things. So I think probably, as I told you before, if our building department cannot cope with the contract, please let me know. Because I don't want to be sitting on money and people will be suffering.
Yeah, quite right.
So I think that's very important.
Chair, it's Jane here, and similar to Syed, I do think we should come. I mean, you're asking the question now, but I do know that similar for children's services and for young people and for families, that there has been some delays in implementing schemes simply because of availability of OTs, which has improved recently, but as Syed's indicated, but then just getting the contractors to be able to implement the recommendations, and also, I mean, I know that you're very aware of some of the cases where we do have schemes that where the house, it isn't possible to adapt it, so we're having to look at alternative accommodation, and like Syed's just indicated, that they're not available, or if they are, we have to wait a long time for them. I think what we will do for the next meeting, we'll do a comprehensive update with some recommendations, if that's okay.
Yeah.
Thank you.
Okay. Nobody else? Thank you very much. All in favor of that Better Care Fund recommendation? I can say everybody say yes. Nobody said no yet. Thank you. Item 40. Item 40, COVID-19 update. Ken, I think you are starting with the job. Over to you, Ken.
He's on mute, Chair.
Thanks very much, Chair.
It's turned into Dominic.
I was trying to exclude extraneous noise, but yeah, so if you'll allow me to share, Firoza or Wendy, I'll share this presentation. And hopefully you have that in front of you. Some of you on this call will have seen this a number of times already, but I think one of the things that I do have to say about this is that the incredible thing about COVID is that we've actually got pretty much live data that we can look at now, and things do change very, very quickly, which I think can be quite an issue in terms of developing our strategy and our policies and our response to COVID locally, because we're getting data every day, which we're trying to understand what it means and develop our policy and strategy at the same time. So we've only to think about what happened in Bolton yesterday to realise that the data is actually important, but sometimes we need to sit back a little. However, I'm going to run through these slides, and I know that some of you on the call have seen it a few times before, so I'll try and rattle through it as quickly as I can. So this first slide then is showing our testing rate and our positivity rate. And I think that's a really important thing. During the height of our testing, we were achieving 500 tests per 100,000 people per day. So that was on around about the 15th of July. Since then, it's come down steadily, and still going down. There's a downward trend currently at 150. So we're now, our ambition is that with 2 mobile testing units, one at Corporation Park, one at Penny Street, and 2 local testing sites, one by the college, which I went to have a little look at today, and that seems to be working well, and one under construction to be completed in Darwin tomorrow. So that's the first time we'll have had a testing site directly in Darwin. So that's really, really positive. So to get that rate back up, to begin to better identify cases, get people isolated and contain the spread of the disease. At the same time then, our positivity rate, which is the percentage of people tested who are positive. So at one time when we had a very high level of testing, that was down to about 2%. It then went up to almost 7% here on the 13th of August. But currently, since about the 18th of August, it's been at about the same sort of level, about 4.5%. So in some ways, with testing coming down and positivity rate being the same, that's giving us a really good signal that things aren't changing dramatically, although we do still have that number of cases here, and we're currently 4th on the national watch list. We were top, first of all Leicester, and ourselves were top of that list in terms of the rate. So what this graphic is showing you is the rate per 100,000 population, currently standing at 48, so that's 72 cases in the last 7 days prior to the 27th of August. So that rate went up as high as 95, it's now back down to 50, and it looks as though it's going to hover around 50 for the next few days. These rates in grey are grey because we've not got all the confirmed data in for that as yet. So the authority that's come into this top 3 now and pushed us out of the top 3 down to 4th is Corby. So that's linked in with the current spike in Northamptonshire, which originally started with a single sandwich processing factory for Marks and Spencer's in Northampton, which had about 300 cases. But now that spike is going into other parts of Northamptonshire, Wellingborough, and now Corby has kind of pushed over. So this is the actual number of daily cases. So for those who've not seen this before, over the past 3 weeks or so, that's been hovering at round about 10 cases a day, roughly speaking. So I think you've got 71 cases in the past 7 days, that's about 10 a day. And there's some variation. We've got a high here of 19 and here, and then lows here of 6, but it's roughly 10 a day, which isn't a particularly great number, but we can't see it significantly coming down. It's staying at around about that level. The other thing that we've done, and the quality of the data is improving, is we've now started getting all of the testing data as well. In the first stages, we only got the positive tests. And I know there has been some criticism of national strategies for purely focusing on positive tests. But we've looked at all of the testing, and what we see is that testing, yeah, it is through the ages, but the positivity rate is much more pronounced. This graphic at the bottom left-hand corner is the numbers of positive tests out of these numbers of tests across the whole of the borough. So we actually see that in the 20 to 29, 30 to 39, positivity rates are higher. And then coming on to ethnic group, again, the data is fairly good. We've got ethnic origins are identified in that data. And the graphic at the top left is a really important one, because what that shows is that the profile of testing across the borough pretty much matches the profile of the population. So we've got, roughly speaking, 60% of all tests were for our white residents, round about 26-27% were in our South Asian residents, and then a further proportion were in amongst other ethnic origins, but there are a big chunk where the ethnic group is not known. So that's the testing profile, and that pretty much matches the population profile of the borough. So that's good. So everybody's going out to be tested roughly. but the positivity profile is very, very different. So this we've seen throughout the whole of the pandemic, that positive tests across Blackburn with Darwin have been dominated really by our South Asian residents, predominantly Indian and Pakistani, in comparison with the testing and the profile of our population. And that's been the same from the early stages when we were just getting the hospital data, and now we've moved into the pillar 2, which is the community testing. The profile has been very, very similar. And as we know also, we're a deprived borough. Almost 2/3 of our population are in the most deprived 30% across the of the British population. So this top bar is deprivation deciles for England, and as you'd expect, there's 10% in each. So from the most deprived purple to the least deprived green, but our population is almost 2/3 in those 3 most deprived deciles. But when we look at our cases, and these are the cases in the last 14 days, almost 90%, looks like about 86% to me, are in those bottom 30% of most deprived population nationally. So there's a big risk factor in terms of deprivation, in addition to the risk factor for ethnic group, and in addition to increased risk factors for specific occupational groups. And another piece of work we did was to look at testing by ward. So we know that in our current strategy, we've identified an intervention area, which is 8 wards, pretty much central Blackburn and the surrounding areas. So those 8 wards are identified in red on this table. So what we see actually is that although those are our priority wards, so they've got the most cases, and it is a significantly more cases than the others, the testing rates are not that much different, and they're quite interspersed across. So in terms of the highest testing rate, it's in Billinge and Bearwood, but that's got a high case rate. The lowest testing rate is in Little Harwood and Whiteburg, also a high case rate. So we have got a quite good testing profile across geographically the whole of the borough, as well as across our white, South Asian and other populations. And the table and the graphic that I'm showing you here, this is the kind of the key data that was really fed into the decision to go for the intervention area. So that showed that these top 8 wards here, the ones where the rates are identified in red, ranging from 290 cases per 100,000, compared with our average that you can now see of 45. Leicester was 137 at its peak overall, so that's quite high. Then down to 74 in Orleans Queens Park. As you went below that, quite below the cut-off figure was around about 60 at the time. So all the other wards are in that category, and some had just a couple of cases. Livesey and Pleasanton, Darwin West and Darwin South had none. I'll move on to the next graphic to show you one of the key features of COVID, which is very much the geographical concentration. So this is the most recent data up to the 23rd of August, split into lower super output areas. So these are the small areas that we're now starting to focus our community testing on. Each lower super output area is about 500 to 600 properties, about 1,500 to 2,000 people. And as you can see, there are extreme concentrations of COVID in some of these lower super output areas, and large chunks of the borough where it's grey have no cases at all. So down into the south of the borough, down into Edgeworth, large parts of Darwin, no cases at all. And that's a real key feature, those geographic clusters, and that's driving our current testing strategy as well. So then the most recent data for our 10 wards, our 8 intervention wards, shows that it has changed even over a week. So in Baswell and Daisyfield, the rate went from 116 up to 128, but you see that that's only one case. So there's one additional case there. Audley and Queen's Park stayed the same, and so on. The key bit then is to treat that intervention area as one area, and certainly we've asked government that review in 28 days from the announcement, rather than keeping a rolling review, because we know the data does fluctuate. and the rates do fluctuate, because in the end we're actually talking about quite small numbers of cases. So if we've got 3 cases and that goes up to 5, that makes a big difference. So I'll just move on quickly. I think the one thing to say is that in the non-intervention area, so this is the total non-intervention area, a week ago the rate there was under 10, under 10 per 100,000. It's now gone up to, it's now more than doubled, and statistical analysis shows that is a significant increase. So although these are small numbers, 3, 2s and 1s, together they add up to a significant increase in that area overall. And these are some of the features that other local authorities are seeing in their data in intervention areas compared with non-intervention areas, and some of the things that Greater Manchester is experiencing between its districts as well. And just to give you an impression that our incident management group is looking daily at the numbers of incidents and outbreaks in key sectors. So we're looking at the care sector, so this is care homes, other supported living, those sorts of settings. And there was a long period of time when there were no incidents or outbreaks in the care sector and other parts of that sector. But over the recent months, there have been 21 on a week-by-week basis, so it's looking like about 5 a week. In workplaces, yeah, there are regular reported incidents, but it does have to be said when you say level that much of the transmission would appear to be community and household transmission. So actually what you have is a large workplace with a number of cases that are linked to that workplace, but the transmission was actually in the home or in the community. And quite clearly, when you look at the risk assessment, the risk of transmission in the workplace is pretty low. Healthcare settings, educational settings, and then places of worship. And there have been a number of incidents in mosques and places of worship and in prayer rooms. We're keeping a very close eye on them. And as you know, working very, very closely in collaboration to make sure that risk assessments are up to date, and we're supporting to have COVID safe environments for worship. Okay, and then the final thing, and this has been a subject of discussion on the radio today about the national strategy, is that although we've had those large numbers of cases and increasing numbers of cases, although they've started to come down again now, that hasn't translated through into hospital activity. And again, you've heard me say this many, many times, at the height of the pandemic, there were more than 130 people in East Lancs Hospital Trust with COVID. It's now down to 4, and for the past week or so it's been less than 4. Actually, it does look like it's going up a bit, but that looks like variation rather than a trend. Each day there's been 1 or 2 people coming into admissions with COVID, and the number of deaths is not increasing particularly quickly, although there have been 2 deaths in the past 7 days. So again, those are things to look as signals that something might be happening, but there's no strong trend as yet. And then finally, just one slide that I would like to share with you, I've probably not shared before. This is a piece of work that's been done nationally to look at excess deaths. So the general consensus is that we won't really know what the excess death position is till the end of the year. But what this graphic at the bottom shows is the little green line for every week, and these are the weeks of the year. So week 34 takes us up to the 21st of August. The little green lines, that's the average weekly deaths based on 5 years worth of data for Blackburn with Darwen from 2014 to 2018. So we can see how in the height of the pandemic in weeks 14 to 22, each week there were quite a number of excess deaths over what you would expect. The dark red is COVID related deaths. So the definition is where COVID is mentioned on the death certificate, rather than necessarily somebody having had a positive test. But we see here in this period, deaths were under the expected level and possibly just started to creep up a little bit again. And we see that in week 34, there were 6 COVID related deaths in Blackburn with Darwen. So there's some quite interesting stuff there. And I know Martin Eden for the council has looked at numbers of deaths coming through into our crematoria and burials, and there are some interesting features of that data that we're trying to get a grip of and trying to understand how that relates to these ONS deaths. So that's the update from me, and I'll just hand over to Dom for the last couple of slides.
Thanks, Ken.
Thanks, Ken. Shall I just do these last two slides?
Yeah.
So just to give you a bit of just to zoom out a bit from Blackburn with Darwen, just to the national picture. So these are two slides from the Joint Biosecurity Centre. This is all our tests and the cumulative incidence rates, but looking specifically at only those under 18. So looking at the cases of younger people, children and young people. And what you can see there is we're just behind Leicester, and then Bradford and Oldham follow us with cumulative incidence rates, confirmed cases in the under 18. So we're the second highest in the country for that. So that is also giving us some interesting information. And if I can do the next slide, please. And this is the picture as of yesterday. And this I think will change by tomorrow for a reason I'll tell you. But this is the basically the National League table, the top 20 of those of interest to the government with their rates. It's a little bit unclear, perhaps, the numbers, but basically what you can see is Pendle, Corby, then Oldham, then us, then Bradford, Rochdale, Manchester, Kettering, Bolton, that's in there now, has shot up. So I expect Bolton will be in the top 4 tomorrow. They might displace us to 5th place. One of the things that this is telling us really is something about the rate, as Ken said, at which things can change. And within a week, this time last week, we were negotiating with central government, as we do every week, on what measures we have, where were we with our containment strategy, what were the rates doing, and what further measures might we need to keep the rates low. And at that point, a number of local authorities in Pennine, Lancashire, made the case that their rates were so low they should come out, as did a number of other Greater Manchester authorities in the northern group of local authorities that are in special measures. So both Bolton and Trafford made the case to come out of the Greater Manchester group. But by the time the measures came into law to take them out, which was yesterday, this morning rather, their rates had gone up quite dramatically. So both Trafford and Bolton were going to come out of special measures in the northern group, northern local authority groups, but then have just gone back in this evening into the group because their rates had shot up. Bolton's, I think, had 40 extra cases within the last 3 days, which took their rates up. What the pattern of spread that's being noticed in those areas are that they're not predominantly BAME. They were white predominantly, and they were in the age groups 20 to 40. So these were adults, young adults. Their spread and distribution in those areas was much more broadly spread than we have as our transmission pattern. And the assumption, well, there's no clear pattern or causal pathway evident. For us in Blackburn with Darwen, we can see a causal pathway to why our numbers are clustering in certain communities, and that is social contacts through friends, neighbours and families. That helps us with our direct prevention work and our interventions that we recommend as effective and those that we think won't be effective. But where you get a widespread, almost random number of cases appearing in rising numbers across the whole local authority areas, you're into quite a different situation, a different scenario. The assumption, of course, is that they will have contracted the virus randomly, probably through eating out, pubs, social gatherings outside the home. That's the assumption. And what I think there is a national view that the cases that we're seeing at a national level are rising on that pattern. In other words, that a larger number of people are becoming exposed in a kind of random way through routine social contact outside of the home, but going about their daily business, and that rate is rising slowly, but is rising inexorably. In other words, it's not going to go back down again. So the baseline rate for the UK, the confirmed case rate, is at the moment about 12, I think. The expectation is this will rise and rise faster as we get nearer to December. And what we can see is this pattern also in other European countries. And in fact, in some European countries, France is a good example, that rise gets to a certain point where the transmission becomes exponential. Interestingly, France don't record any of their confirmed case data by ethnicity. So we're unable to see whether France's patterns reflect some of the challenges that we have in the UK around a specific focus at the moment anyway on BAME communities. But what's clear from France is they have got a much more universal transmission, and we're expecting a number of other European countries to follow that trend upwards, as we are with countries across the country. I think one of the conclusions we can draw from that is that number one is that the rates rising, as Ken's identified in our non-intervention wards, are probably also being subject to those same pressures. So in other words, there are contacts occurring in the social domain, but outside of the home setting, outside of friends, family and neighbours, because we know that that wouldn't be the mechanism, otherwise they'd be clustering as they are in some of our areas. And we can guess that those rates will gradually continue to rise. And at some point, central government will have to bring in other control measures nationally. The slight benefit for us, of course, is that we've gone through a lot of the control mechanisms. We've got our systems honed and improved in terms of how we control outbreaks and other issues and higher rates. And our negotiating strategies with government are more experienced now than they were. So we are in a stronger position, I think, as the country experiences rising rates. We are in a stronger position by the fact that we've had high rates and we've been managing those. And we just need to build on that experience and continue to manage, as we are doing, successful reductions in the rates in some of the areas where we've got continuing high rates. The final thing just to say is that we are starting the community testing this week. So that is people going out into areas where we know we've got high rates and clusters, both spatially and in family settings in households. And we're delivering 10,000 swabs over the next 4 weeks by basically knocking on the doors saying, here are some swabs, here's what you do, we'll help you to do the swab if you are nervous about doing it yourself. We'll come back in a few hours later this afternoon and pick them up, and we'll send them off for testing for you, and you'll get the results by text, etc. So we're doing that. That will, I think, bring our rates that were going down in our intervention areas, that will take them up again. So I expect by this time next week, we will be reporting rising rates also rather than falling rates in our intervention wards, but that will be a good thing. That will be our exit from special measures now that we've got that very local door knocking, shoe leather epidemiology and contact tracing happening. So we've got a bit more pain to go, but I expect in the longer term we will learn from that, and we will learn how to manage this faster than many other places have had to. I think in terms of time scale, we asked for, as Ken said, we asked for 4 weeks for the current measures with 8 intervention wards to be in place. I am doubtful at the end of that 28-day period we will be down to the national average. Bear in mind the Leicester, which started with a full lockdown, has had some easements recently, but Leicester has taken 7 weeks and it still is not got yet down to the national average and is still in special measures. I think we'll be quicker than Leicester, but I think it will take us longer than this current round of special measures to completely exit down to national average rates. But I'm confident that if we can get more control over the testing and the tracing locally, we will manage that. So that's it.
Thank you very much, Don. Thanks, Ken. I think it's very detailed presentation. I will take any view from our partners. The majority of my colleagues, councillor, they heard these presentation a couple of times. So I would like to see what Vicky and Angelia think about it, how we are moving and what we can do together, and any ideas, any proposal. Vicky?
Yes, Chair. Yeah, I mean, clearly it looks like it's going in the right direction. I think for me, the critical thing is to keep the why message really clear, because I think people are fed up of it. They're not necessarily prepared to stick with restrictions unless it's really clear why it's important. So that why message needs to be clear and consistent across the board and across the borough, actually, because if we're starting to see small increases in other areas, we need to have that same message, don't we? And I suppose that's really what I'm hearing. We know that even people in risk groups are out and about, so that we need to be really clear. And I think that the message about testing and why that's important needs to keep being reinforced as well, more generally than just in those intervention areas.
Thanks, Vicky. Angela?
Yeah, I agree. I think it's especially with the schools going back this week, I think we'll probably see another spike in the numbers across the board. I think it's interesting to see that. I mean, I think it's fantastic that the stuff that's being done by the partnership in terms of containment, but interesting to hear that there is an escalation outside of those target areas at the moment, and that is bound to just get worse, really. And so it is reinforcing that message to those populations that haven't been previously targeted, and ensuring that the messages are clear and simple. That the opportunities for testing are widely advertised. So obviously through the sector we can help promote those messages and get the information to across the borough, really, not just to the vulnerable target groups as well.
Could I just ask a question of Dom? You mentioned the testing in Darwin, so would we logically then expect case numbers to go up in Darwin, and what's then the local response to that in terms of interventions or fairness across the borough? And do we think there's a risk that actually people won't go and get tested because they think that increases the risk of further lockdown? Because all of that needs to feed into the comms and engagement messages across the borough, doesn't it?
No, you're absolutely right, Vicky. And there has been that view that if you don't get tested, the borough will have low rates and you'll exit. The problem with that strategy, of course, logically, is it only lasts for a while. Yeah. Because inevitably confirmed cases will become visible to the system. And if you wait until you've got a larger number of people infected and some of them then entering a hospital setting or certainly needing clinical treatment, you'll have lost it completely by then. So, that strategy's that's President Trump's strategy. That let me just leave it there.
I'm not suggesting that should be our strategy, but I do think that reading local comments in the media, there is a trend around about that. Yeah.
No, absolutely, and I get that, and we have been trying to do some comms, and we will be doing more on that. The issue of the easier you make the access to testing, the more likely people are to get tested. The danger is you get the worried well or the very low risk people getting tested, in which case your positivity rate goes down, which can look good, but is giving you a false signal. What will happen, for instance, when we start the community testing, where we're targeting at very small areas, areas where we know yesterday had high rates by postcode, is our positivity rate is going to jump. When Leicester was locked down, it got to a positivity rate of 10%. So 1 in 10 people that were testing were coming out positive. We hope we won't get to that. But the more you target the testing, the better. I think the issue with Darwin having a local testing site is that if you think about, if we accept that COVID's going to be around for 2 years at least, possibly longer, what we need to do is normalise the capacity to be tested. You know, it might be something you do when you pop into town one Saturday because you've had some symptoms or you've had contact. And, you know, within a few months, we are going to get a much simpler testing system that will be basically just a spit test, which will be much quicker as well. And what we need to do is normalise that behaviour so that people can identify themselves as at risk, get tested, self-isolate themselves much quicker, because the quicker that cycle goes from risk, symptoms, test, isolation, the quicker that cycle goes, the more rapidly we shut it down. So I think when we do set up the site in Darwin, there may be some reluctance to turn up for a test. But I think we will get more people from Darwin testing. I mean, we have looked at the testing rates by ward to see whether there was any testing bias in the testing we've had already. And although there are variations by ward, surprisingly, the levels are broadly equivalent in each ward. And also we found, for instance, that some wards that had lower numbers testing actually came out with higher cases. So we're confident that the testing isn't generating a bias in the confirmed cases by ward. But the more testing we can do, because we're an area of known high transmission, the quicker we help people isolate, the quicker we shut down the number of cases. So it'll be those areas, that the areas I would be increasingly worried about in the future are some local authority areas, and quite a large number are testing at a rate of less than 80 per 100,000, getting very low rates of confirmed cases and saying, oh, we're all right, we haven't got a problem. But actually at that rate of testing, I'm not sure you would know whether you had a problem, to be really honest. And we've set ourselves a target as part of our control strategy with government to get our testing back up to 500 per 100,000. When Oadby and Wigston came out of special measures, they were one of the first ones near Leicester. They got their testing rates up to 1,000 per 100,000 and shut it down very quickly.
I guess it's about turning all of that into simple comms messages, and isn't it, about why we need to do what we need to do.
Yeah, no, absolutely, you're right, Vicky. Yeah.
Thanks. Anybody else have any questions?
Yeah, question from me, Chair, if you don't mind. Regarding these sort of the targeted approach, Dom, you know, going door to door and asking people to do the test themselves. I'm a little bit sort of concerned with the fact that I've had sort of trained personnel standing at test centres who haven't been able to perform that testing, you know, 100% all the time. I'm just worried that people, if you just leave them to their own devices to do the testing, we could potentially, you know, end up with a lot of voids in there, you know. So I'm just worried about that. And the other thing I was sort of just going to, I think Vicky's just touched on it as well, is so we've got the 8 in the extra measures, and he said that, you know, we've got sort of rises in the other wards as well. Another concern again that there's going to be, you know, some frustrations from the ones that are locked down if you don't, you know, sort of apply it across the board. You know, I don't think we need sort of, you know, global tighter lockdown, but I think there needs to be some level of parity.
Yeah, no, on that last point, you're absolutely right, and that is now, I think you'll probably see on the news at 10 tonight some discussion on that because of the most recent you know, GM local authorities zooming in and out of potential special measures and back in again. I think that the issue here is what period of time is safe to allow an area to be in or out of measures before you change their status. because the problem is, if you set a level at solely at a number, you fail to make a broad enough judgment. So I mean, at the moment, those local authorities that are getting into being of national interest are somewhere at a rate between 20 and 25 per 100,000 confirmed cases. So if you get above that, the Joint Biosecurity Centre starts to look and see what's going on. And of course you can get spikes, one-off spikes, which you might not be worried about. So a one-off spike, for instance, could be caused by a big workplace outbreak, but the rest of the place, the rest of the borough isn't being affected, but you've got high numbers. So the judgment has to be slightly broader than just the numbers. But I think we will see a tightening up of the criteria, because there are some inconsistencies with the way in which the current control strategy is framed, and it's very much a live issue. I think what we don't want is to set a level where people yo-yo in and out of special measures. So there has to be a broader set of criteria to decide whether a place is of concern enough to intervene. And in the discussions with central government, one of the things that they use in their judgments about that is whether or not they feel that the local authority understands what the problem is in control of the pandemic locally, and is capable of making its own judgments. And so what you won't get is a sudden intervention if you go above a certain level, if central government are confident in your local management of that and the fact you understand it, but you have to make the case. So we were successful in making the case for half of our borough to come out. And you know, the figures that Ken showed you about the confirmed cases as a rate in the intervention boroughs versus the non-intervention boroughs shows a very big difference between those two, although that will change over time. So we will keep it under review. So we have a weekly review with central government, and believe me, they will press us on if we get some of those wards that are not in the intervention group rising very quickly. They will press us on that question. Why aren't you adding this one to the intervention group? And by and large, if we're convinced that there's a significant risk there, we will do. So we'll just have to move with the numbers as they appear, and that's exactly what Bolton's had to do, for instance, today. On the other issue about voiding, it is very difficult for individuals to do the test themselves if they have no medical training to swab themselves. Each of the teams that is going out from the council will have a trained NHS staff member, trained swabber with them, and we are both offering support and instruction, but also they will do some swabbing if people feel particularly uncomfortable or that it's too difficult. I mean, there are instructions with the pack. You get a pack with the swabs in with detailed instructions on, and we've got translation services and things also supporting that team. But we're doing the first 3 days starting today, so we'll do 3 days this week, and they're going to learn from the experience of the 3 days, and I think they'll get better at both contacting people, supporting them, giving instruction, finding out what problems there are, and we'll get better at it over time. But we are going to have to be doing this, in my view, I mean, not just Blackburn with Darwin, but nationally, for the next year or two. So we've got plenty of time to get better at it.
Okay, thanks for that. Just a couple more. I think one for Ken. You know, the last graphic that you showed with the super output areas. I believe there's a week's delay on that, but when I visited the site yesterday, it was indicating that it was up to the 28th, which was sort of a little bit confusing for me because I thought it was the 23rd. That's the first one. The other one was to Jane. Any early indications from the schools about how things are going, how things are progressing? Because I know the full cohort will be sort of back in next week. Have there been any challenges, etc.? Just wanted to understand that. And there was another one for Dom, but it's just gone out of my head completely.
That's fine.
Chair, do you want me to respond to Mustafa? Just to say, we've had, as of yesterday, we had 4 schools return. So far, attendance has been between 94 and 95%. with, I think, children delighted to be back, parents thrilled that they're going back. But I have no doubt, as Dom and I had a discussion earlier today, that we will begin to see, despite everybody's best efforts and the comprehensive risk assessments and the hard work of absolutely everybody, it can be challenging, can't it, for children, particularly in primary school children, to socially distance at the best of times. So we are planning for multiple outbreaks in a number of different settings, but so far so good, Mustafa. Thank you for asking.
That's great, thank you.
And yeah, and just on the data, yeah, that there is a kind of a bewildering array of data and dates that are used across the piece. But the slide that I showed you is taken from, we receive a report each day called the Local Authority Daily Report, which provides those graphics by lower super output areas. So those are the ones that we currently depend on. But so yours is, so what's the one that you're referring to, Mustafa?
You know, the one that that link that Dom sent out, where you do sort of week by week analysis of the hotspots in and see the infection rates. Yeah. So I thought there was a 1 week delay on that, and when I looked at it yesterday, it was showing me that it was up to date to the 28th, which was.
Okay, I'll follow that one up for you.
Okay, and I've just remembered the question to Dom. Dom, how are we measuring the impacts of the interventions? Because the positivity is not going down. Today it's gone up, and the tests are going down. So how are we measuring that?
Yeah, on the tests going down, we know what the reasons are. Basically, what's been happening is well, there's a few things contributing to the testing rates going down. One is we think a lot of the things Vicky was referring to, which is we've got it's kind of behavioural decay in the population. So they're getting worn out and bored and fed up and also dubious about the consequences of testing, despite, you know, a lot of the comms messages we're putting out. And we understand that, you know, it's entirely understandable, and we just need to get better at and more sophisticated at the comms and messaging. We've also had a lot of fake news about testing. I won't repeat some of the stories because they're so ridiculous, but a lot of them are actually coming from the United States, which is quite interesting culturally. So that's one reason why testing rates have gone down. The second one is the lab capacity in the UK is affecting the ways in which you can access the testing online. So if you go online through 119 to book a test, sometimes you can't book one in Blackburn with Darwen, even though we're a pilot area and we're told we would be given priority. And the reason is when the labs run to capacity, they simply take the ability to book a test offline. So it's not even on you can't book one basically until their capacity resumes and they put it online again. And we've had that, for instance, over the bank holiday weekend. We've escalated complaints and all sorts, but it's been happening all over the country, including in the three areas in special measures. So we're not very happy about that, because of course that also destroys people's confidence in getting tested. But that's a national capacity issue. So that's those two things. What was the other bit?
It was just about sort of just around what the impact. How do we measure the actual impact? Because you know, in terms of behavioural changes, I've seen very little since the additional sort of measures were put in place in these areas. People just seem to be sort of going out doing business as usual. So I'm just wondering how it's sort of helping the whole situation.
Yeah, well, we've got some indirect measures. So we've got measures from the Public Protection Service about their inspections, their actions on enforcement, for instance. We've also got police data on enforcement. We've got data on informal information we get through our various COVID inbox and through other routes into the council, with people alerting us to certain situations. It's definitely true that there are either increasing examples of non-compliance or increasing examples of people willing to report non-compliance. And, you know, this is exactly what central government predicted would happen with any kind of lockdown or social control measure. And we have to find ways of strengthening the compliance with the guidance and the regulation. I think in general, we are confident that the majority of the population are going with the changes and with the guidance that we're giving, but clearly there's still some non-compliance. And it's a mixture of three things. One is education, the other one is engagement, and the third one is enforcement. And we are working hard on all three, but all the areas that are under special measures are having similar challenges. In the end, the only indicator that matters is the confirmed case rates, really. You know, if those go down, with the outcome is successful. But of course that depends on a certain level of testing, and although our testing rates have gone down, we are testing about 50%, 60% more than the national average. So we're still at a much higher testing rate than the national average, and now we're doing the community testing, that rate will go up significantly.
Okay, that's great. Thanks for that.
Thank you, Dom. Anybody else? Somehow it's
Yes, please.
System is not working. I don't see any hand or any conversation on my page.
Chair, can I ask a question to Dominic?
Yeah.
Please? Yeah.
Okay.
Thank you. Because there's no hand on the screen for some reason.
No.
I just wanted to ask Dom, do you think people with low income being able to put a claim in to self-isolate, that will encourage people to come out testing? And obviously people going out to do the house-to-house testing started this week, as you've confirmed. Will that coincide with putting that claim in for people and help encourage the testing rate to go up?
Yes, we definitely hope it will. For those of you that don't know, we made the case along with Oldham and Pendle, Lancashire County Council, for people who are on 0 hours contracts, precarious employment, or self-employed, or low incomes, to be able to claim some money if they had to basically stop working for 10 days while they self-isolated. And we know from our test and trace work locally that people are saying this is one of the reasons why they don't want to give all their contacts, for instance, to the National Contracting Centre, because of course your first contacts are most likely going to be your family. If you're a confirmed case, your family members are going to have to self-isolate for 2 weeks. If they're self-employed or in any of the other categories, they're basically not going to have any income. And so people have been reluctant nationally, not just in Blackburn with Darwin, to respond to the national test and trace system, but especially in poorer areas. So we know that, for instance, Cheshire has over 90% responding to the national test and trace system. In Blackburn and Oldham, the rates are between 50 and 60%. So that has been a big disincentive to collaborating with the national system. So we did articulate the case for support, financial support, if you have to self-isolate. Obviously means tested. So there's some criteria you have to meet. And the government have set up a pilot scheme now, which is running. Details are on our website. So you get 13 quid a day if you self-isolate. A lot of people feel, I mean, what we asked for, actually, we asked central government, we said, we think self-isolation is a civic duty. Please, could it be treated in that way and be treated like jury service? And if you go online and look at the payments for jury service, you get 65 quid a day if you're self-employed or in any of those other categories. So I'm not sure that 13 quid a day is a massive motivator, but it is something, and we will give feedback to central government about how this is going. We've already told them we think it's too low, but it is at least some progress, and it's happening for our residents rather than nationally. So we're a pilot scheme in this. Anyway, 13 quid a day. One can only conclude that the Treasury officials that designed that payment amount must live very frugal lives, or they think people in the north are perfectly okay to get by on 13 quid a day. Oh, yeah. One of the two must be true. But Yeah, and the answer, will it make a difference? I think it will help, but I just think that that financial support system is just not enough. And you know, in clinical terms, if this was a drug research and the drug was an intervention for a disease, it's called a type 2 error, which is where you give the right drug but at the wrong dose. And that's what's going on. It's a type 2 error. I've told them that.
Thank you for answering that.
Thank you. Anybody else? No. Vicky, Angela, I think whatever message you can give to your organization, I think Age UK is very big organization country-wise. Maybe something can come from a national level or probably on local level to make sure that people need to have some kind of prevention in their mind. If they go out, what they do and how they meet with the people, etc., etc. So I think these messages are very important. As you say, it need to be a clear and consistent message always to the community as a whole. I think the testing is some of the biggest issue which I'm feeling. And I think we have quite a few testing stations, one in Corporation Park, one in Blackburn College, one is further down to Town Centre, one in the hospital, Bank Line, 4 of them, one going to Darwin. But it seemed to me that are about 900 odd from each ward, maybe 800 odd from each ward. And each ward population is around about 5,000 population. So it seemed to me that it's very, very low. And I think we need to think about it. What is the best way forward to encourage the people to go for testing? And a BME community, I think there's clear message coming from some of these videos, which are from United States and in their own language. Don't go for testing. That is the way to kill you. And I think that is really terrible to me. And I've spoken to my communication department and I said, we need to look something with Council of Mosque, Lancashire Council of Mosque. Maybe we can have the same message in the outly area in 5-6 mosques on Friday prayer. Somebody need to go and explain to them, maybe local council can go and please, this is a good opportunity for you to get tested. People are coming at your home, you don't have to go anywhere else. Corporation Parks, Dom, I think most of our is the issue felt self testing. It's all self-testing in corporation ward. They only advise you what to do. They will give you a kit, you open the kit yourself, they tell you what to do. And I think majority of the people, they were very successful. Maybe 1 or 2 people probably missed it, but I think it was very successful. And I think if somebody explained to the people at the front door how to do it, it's not a difficult process. I've done myself. When I was in corporation ward, it took me only 5 minutes. They only explained to me, and that was it. Within a 24, not less than 24 hours, I have a test about 11 o'clock in the morning, and 3 o'clock in the morning, I got my text message. You are okay. So I think testing is one thing we need to encourage the people to get tested. I know that probably number will go up, but in long run, I think we could be in better place. So I think that's something we need to push. And I think especially the people who have myth in their mind, I think wrong message coming through the video. We need to beat those myths that people fully understand that testing is not going to kill you. The testing is going to save your life and your love of life. Okay. I'm really disappointed that nobody here from the East Lancashire Hospital and CCG. I think they are the great partner with us. They can tell us what's happening in hospital. They can tell us how the GPs are preparing themselves. I think I was discussing it, Ken, earlier on. The GPs are still not looking the people face to face. And I think that is my real concern. It's still on the telephone, which communication on anybody, you won't be able to explain to the doctor because you are not a doctor. So I think this is something, Dom, I think we need to raise with CCG. The all GP need to change their attitude, that they need to look at the patient who are really suffering. And they just ask, I think it's happened to me today with my wife. She's long-term condition, COPD and other things, 120 other things. And I spend bloody half an hour to try to explain the doctor, but still, I say, she must see you. No, I'm sorry. I can only advise you on telephone. So it's a guesswork. They're given the antibiotic, etc., etc. But and I think GP has to took some kind of, maybe it's not a risk. I think other people are doing in the town center or probably in the council face to face. People are serving the customer in Mark and Spark and other places. So I don't know what is the problem with the GP if they are putting the proper kit to look at the patient. So I think that's the one thing I think Dom, I already raised with Omar Mohammed, who is representative of CCG, but I think if Graham was there, I could have put him in the right spot because this is something we need to do it. And same thing Bly Hospital, I think we need to write a letter. I think if Feroza, you can start out the letter from myself, I will be able to sign it, requested then a partner that this is a very difficult time for all of us. Time is very difficult from their side to give to us, but I think this executive board, health and well-being board is very important, where we can share the information and we can help with the community how we can move forward. So please, if you don't come, send substitute who can give us information about the hospital, what's happening there and what's happening with the GPs.
Yeah.
Oh, anybody else? Any question? Any comments? Suggestions? No. That is end of the meeting. I don't have date of the meeting in the future. Maybe Feroza will send you one.
Yeah, I can send that out in the future.
Okay.
Yep.
So if no,
I'm not going to add any more time, but maybe at the next meeting I could give a brief update post the HAF program, the Holiday Activity Fund program that just finished last Friday in Blackburn with Darwin. I only need to give a very brief verbal update on it, but I think it'd be useful just to give some feedback from ourselves as the project contracting organisation, but also from Department of Education, who came for a visit to Blackburn with Darwin last week.
Thank you, Angela. Thanks a lot.
Great.
Okay. So nobody else has any burning questions? Thank you very much. Have a nice evening. If you are in kitchen, go back to kitchen. If you are driving, have a safe journey back home. Dom, I believe you are going away for 2 weeks. You deserve this break. I think I was saying to Denise a week ago, please send Dom away for 2 weeks. He need probably some rest. And maybe when you are away, we will be able to sort out this COVID.
Yeah. I'll be looking every day to see how you
Dom. I hope you are not leaving the country because you will be isolating yourself for 2 weeks if you come back. So stay here.
I'd recommend Croatia, Dominic.
Yeah.
Chair, just to let you know, the next meeting's at 2nd of December.
Thank you very much. Maybe if something comes up, we'll probably have an earlier meeting to give some feedback to our member who don't want to wait for 3 months. But it's all depending on how things are going to move forward.
Yeah.
Okay. Thank you very much, everybody who attended this meeting.
Thank you all.
Thanks a lot. Take care.
Good to see you guys.
Thank you very much.
Bye-bye.
Take care all.
Cheers.
Cheerio.